half of you that registered in the room, and we want to be respectful of your time and also our presenters' time. So we're going to go ahead and get started. Welcome everyone to today's webinar. My name is Daniela Labate-Cavelli and I work at Navigators. So today's webinar is peer support in addressing health disparities for Latino and African Americans living with major mental health challenges. And we're so pleased to see all of you joining us today. We're going to get into it in just a minute. I just have a couple of housekeeping things to sort of review with you. So the first is that the webinar is being recorded, and today's webinar recording and the PowerPoint will be posted on the NIAPRS website, and I'll put that in the chat box, but it's also www.niaprs.org, and that should be posted within the next 24 hours. Everyone that attended today will receive an email with an evaluation, and that will be sent to using the email address that you used to register for today's event. And so the purpose of that evaluation is twofold. One is we always appreciate your feedback, and we want your feedback. The other is for the purpose of CEUs. We are offering 1.25 CEUs for today's webinar for LMSWs, LCSWs, CPRPs, and LMHCs. And we ask that you fill out that evaluation and return it within 1 week. So you definitely have a deadline for that evaluation if you want to get CEUs. We ask that you send it back within the week. And then we ask your patience on our end because, you know, NIAPRS has been doing these webinars since April. And since April, we've had over, I want to say it's like over 6,000 individuals joining our webinars. Today we have about 600 folks joining today alone. So if just half of you want CEUs, it's a lot for our office. So we ask that you be patient and kind with us. The turnaround time for CEUs has been about 45 days. So we ask that you hang tight and wait those 45 days for your CEUs. We do promise we will get them to you. We've had some great conversations in the past on our webinars. We hope to continue that today. I already see you using the chat box, which is fantastic. Please do use the chat box and type in your questions so that we can all see them. I'll be keeping track of your questions throughout the webinar today, and then we've set some time aside at the end for Martha and Pamela to address your questions. So please feel free to do that throughout the webinar today. And with that, I'm going to turn it over to Harvey, who's going to introduce our panelists. Thanks so much.
Thank you, Daniela. Daniela is the Director of Managed Care Readiness here at NIAPRS, but she has been our WIS coordinator of all these webinars. We've been, as she mentioned, putting on webinars since the beginning of COVID as a public service. And so we really try to pick the themes of the day that are most relevant, and this theme is particularly relevant. I'll get a quickie on NIAPRS. NIAPRS, if you don't know, is a state and national change agent dedicated to improving services, public policies, and social conditions for people with mental health, substance use, and trauma-related challenges by promoting health, wellness, rights, and recovery with full community inclusion so that all may achieve maximum potential in communities of choice. Memorize this because I'm going to ask you to spit it back to me later, okay? What we do in that service to that mission is we advocate. We do a lot of grassroots advocacy. We do a lot of public education like this. We do a demonstration. We created the peer bridger model, and we celebrate recovery in every opportunity we can. And speaking of celebration, our biggest celebration is the annual conference. And lots of people are asking, when is it going to be and where? This year, we're going to have to, like many groups, make it virtual. I think we're talking about 2 half days in 2 successive weeks, so 2 half days, 2 half days. And we haven't picked a time yet, but stay tuned. Go to the homepage, and you'll see a place to sign on for what's called the e-news, and you'll be able to get information about that. So we're very fortunate to have 2 pioneers in studying, implementing, and promoting the unique value of peer support in advancing the health and wellness of people with mental health challenges currently and moving forward. It's particularly important. During all this time, we're talking about racism and health inequity and disparities. One of the reasons we're so excited about these folks and the work they do is they really look at overcoming health disparities through the power of peer support. So we're very, very pleased about that. I'll tell you a bit about them, and then I'll stop talking in a minute. One of our presenters is Pamela Goodine, and she's a certified peer support specialist with the Forsyth County Department of Public Health Stepping Up program, where she assists peers with identifying factors that promote wellness and recovery. During her recovery process of dual diagnosis, she gained certification as a North Carolina Certified Peer Support Specialist, CPSS trainer, and a Level 2 Wellness Recovery Action Plan trainer. Pamela serves her community in many capacities and is a co-chair of Forsyth, I'm dropping my paper here, Forsyth County Mental Health Substance Use Disorder Advisory, the member of Triad Consumer Family Advisory Committee and Cardinal Innovations Steering Committee. And as you heard, she's from North Carolina, and so is Lori Coker, and we want to welcome you, Lori, to the webinar. She's also the chairperson of the Bonnie Shell Scholarship Subcommittee of North Carolina CANSO. She's done it all, and she's a member of the National Association of Peer Supporters, or INAPS. Her favorite quote is, "My mission in life is not merely to survive, but to thrive, and to do so with some compassion, some humor, and some style," and she certainly has style. And that's a quote from Maya Angelou. Martha Barboni served in the USAF, United States Air Force, before being sidelined by a diagnosis of depression and PTSD. After several years, including multiple hospitalizations, medications, and other treatments, he was introduced to peer support. This led to newfound hope and discovery of inner strength. Martha has worked as the director of CPS training and provided peer support on an inpatient unit in a peer-run organization and facilitated groups in the VA. She's a member of the Recovery Advisory Board and the Veterans Engagement Stakeholder Council for the VA Healthcare and Implementation Research Program. She is currently the Interim Director of Operations for INAPS, National Association of Peer Supporters. Please check them out. It's a fabulous group. It is the nation's preeminent group on peer support. Go to their annual conference. I was there last year, and Martha did a wonderful job on peer supervision. And it's really a rich program. So please look for that, whether it's virtual or not. Finally, the third person that's not here is the other partner here, and that's Patrick Corrigan, who's the Distinguished Professor of Psychology at Illinois Institute of Technology. He's the nation's foremost expert on stigma, the editor of a new journal published by the American Psychological Association called Stigma and Health, written over 400 pieces and 15 books, most recently, The Stigma of Disease and Disability. In today's context, Patrick has been heading up several projects, of which this is one of them, examining integrated care, primary behavioral health care, and health disparities framework. So it's my great pleasure to turn it over to our presenters today, and I will disappear until the end.
Thank you, Harvey.
Thanks, Harvey. So it's truly an honor to be here doing this presentation with NIAPRS today, along with Martha Barbone. And thank you, Harvey, for such an excellent introduction of each one of us. And so we're here to talk with you today about peer support services being used across the United States to address the health and wellness of health disparities for Latino and African Americans living with major mental health challenges. So this presentation was developed by a dissemination team comprised of leaders from the Chicago Health Disparity Centers at the Illinois Institute of Technology and the International Association of Peer Supporters, also known as INAPS. The Chicago Health Disparity Center is a group of investigators and persons with lived experience that examine the health and wellness needs of people with serious mental health challenges. The team also examines the barriers caused by public stigma and self-stigma. The ultimate goal of the center is to improve the quality of health while simultaneously eliminating the effects of stigma on health conditions for persons with lived experience. Serious mental health challenges are defined as mental health concerns that hinder the individuals from achieving their specified life goals. And I'm going to turn it over and let Martha tell you a little bit about INAPS.
Thank you, Pamela. INAPS is the National Association of Peer Supporters, and we're an organization whose mission is to grow the peer support profession by promoting the inclusion of peer specialists throughout healthcare and other community systems. Our presentation today is based on a view of hope and recovery, and I'd like you to consider what Christian Larson said: believe in yourself and all that you are. Know that there is something inside you that is greater than any obstacle.
Okay, so again, my name is Pam Goodine, and I'm a certified peer support specialist, not only with the Forsyth County Department of Public Health, but also at Green Tree Peer Center, which is a peer-run organization. So I'm just very thankful because it's places like Green Tree that has helped me in my process of recovery. I've been doing the work of peer support for about 12 years now. I began working with an ACT team in which I basically met people where there was at and assisted them on the road to recovery. But this is the first job that I have been able to hold, and it's all due to me being connected to the right resources that encouraged me and helped me along my way.
Thank you. And I became interested in research after I made the transformation from being merely a recipient of services to being an active collaborator in my treatment. Participation in research activities with the VA has given me a greater awareness of the research community, and I've been fortunate to share my experience and be included in planning of the future research focus. I look forward to sharing information on participatory research with all of you today.
Okay, so this presentation will review the value of peer support providers based on PCORI funded research in assisting people with mental health challenges in attaining their health and wellness goals.
The Patient-Centered Outcomes Research Institute, also known as PCORI, helps people make informed healthcare decisions and improves healthcare delivery and outcomes by producing and promoting high-integrity, evidence-based information that comes from research guided by patients, caregivers, and the broader healthcare community. PCORI is a United States-based non-governmental institute created as a result of the 2010 Patient Protection and Affordable Care Act, also known as the ACA or Obamacare. Development of this presentation materials, as well as the Speakers Bureau, which Pam and I are a part of, is made possible by a Eugene Washington Award Dissemination Initiative that was proposed by the Chicago Health Disparities Center and the National Association of Peer Supporters. All materials and comments in this presentation are solely the responsibility of the dissemination team, and PCORI is not responsible for the presentation of these materials.
Okay, so here I want to summarize what will be reviewed in this presentation today. First, we will talk about the problem, the reason we are here today. People with mental health challenges get sick and die 10 to 20 years younger than the same age peers. The problem is even worse if they are persons of color or from low-income communities. One reason is because health services that would improve health outcomes for this group are lacking and or fragmented. So we're going to talk about the health and wellness of people with mental health challenges. We're going to describe the peer support services as an effective solution. We're going to describe program development through community-based participatory research, the PCORI research findings, and how peer support services might be implemented moving forward.
We've shifted from a maintenance-based model where the best that was hoped for was to maintain a level of symptom control to a recovery-focused approach that emphasized those with mental health challenges can and do realize many of their hopes and dreams, even if some symptoms remain. Effective programs and providers embrace approaches that promote hope, and they do it by empowering connection and collaboration. People with lived experience determine for themselves what services they wish to pursue to address their goals.
Okay, so let's take a look at the first point on the presentation. What is the issue? Specifically, what are health and wellness concerns of people living with serious mental health challenges? First, evidence-based practices show that the best journey to mental health improvement is through recovery-focused ideals. All of the information provided in this presentation will be in person-first language and recovery-focused approaches.
So you're going to see a variety of health systems, health concerns. As you can see, as these pop up, people living with mental health challenges have physical health problems that affect almost every organ system. I think we're all very aware of the more common ones we hear about. We hear about obesity and cardiovascular disease and high blood pressure. People are more prone to respiratory disease and even orthopedic injuries, because often people become unstable on their feet and there's falls. And what has been particularly evident recently is this group is also more prone to communicable diseases and infectious diseases such as COVID-19.
So we had no idea that this pandemic was going to come. So the COVID-19 is a viral infection that causes respiratory illnesses that, when severe, can lead to death. So people all across the United States have had to institute precautions to keep from being infected by this disease. This includes sheltering in place, maintaining 6 feet social distance, and wearing masks in the public, as well as washing our hands. If a person believes they are affected, they should promptly be tested from a qualified medical professional. If they are positive for the infection, they should then receive treatment from the medical professional. Sheltering in place has led to significant stress and social isolation, in which may worsen the mental health of people already vulnerable to psychiatric illnesses.
These physical illnesses left untreated can cause negative results. People with mental health challenges use the emergency room more than their same age peers for physical health problems. They may often become disabled due to limited mobility, along with the inability to meet personal goals related to education, work, or independent living because of physical illness. Often people end up in an institution, and despite the fact that state hospitals have faded away in great numbers because of deinstitutionalization, many people may end up in nursing homes, 24-hour care centers, where people get the care needed that they cannot provide for themselves. And as we have heard, people in this community often die 10 to 25 years younger than the average.
So in addition, physical illness undermines wellness. People living with serious mental health challenges report a lower quality of life because of sickness. Many are less satisfied with day-to-day activities. They report a lesser sense of peace, serenity, and calmness. They state experiencing a feeling of inadequacy rather than a sense of wholeness. We do not mean to say that illness and wellness are separate experiences, that they are treated separately. Rather, they do exist on the same continuum.
So just for the purposes here, what do we mean by serious mental health challenges? And the definition is a diagnosable mental behavior or emotional disorder that causes serious functional impairment that substantially interferes or limits one's major life activities. That's the SAMHSA definition. People often may be dual diagnosis, where they have a mental health diagnosis as well as a substance use diagnosis, alcoholism or other drug use. A mental health challenge can lead to disability. Disability is facing difficulties to achieve personal goals related to education, work, independent living, relationships, and health. And this is much more encompassing than the Social Security Administration determination of disability, which is based solely on one's employability.
So the problem of illness and death among people in this group is worsened by several things. People of color with serious mental health challenges are likely to show more illness and earlier death. People who are poor have worse health outcomes, especially if they are homeless. Crime worsens health. Crime victims get sick more often. But so does the person who commits the crime, especially if they become involved in the criminal justice system. Excessive use of alcohol and other drugs worsens health outcomes.
We're going to discuss 6 reasons why we see worse health outcomes in those with mental health challenges. First is lifestyles. These are typically modifiable health risks and behaviors that can make health outcomes worse. People often fail to eat from healthy food groups and actually make health worse by poor diets, high in fat, sugars, and fast foods. People not only need to know what foods are healthy, but they need to be able to access these foods. People who live sedentary lives often have worse health outcomes. Simple things like walking every day can improve health and wellness significantly. We have heard for years that cigarette smoking is clearly recognized as detrimental to overall health. Unsafe sex and other behaviors can lead to hepatitis B and HIV infection. Regular practice of safe sex, for example, the use of condoms, reduces communicable diseases significantly. And as we've said, alcohol and other substances can and often does worsen physical illness.
So the social detriments of health are particularly important in determining the experience of persons living with serious mental health challenges. These experiences may lead to trauma, which can further worsen the person's physical and mental health. Many people with mental health challenges, because of their illness, have a limited income and become poor. Poverty at its worst causes homelessness. Many people do not have a regular place to reside or housing security. They may couch surf, live in abandoned buildings, or live on the streets using shelters only when the weather is overwhelming. This group is more often victims of crime, especially robbery and assault. They may also be more likely to experience domestic violence, most typically violence and assault from a family member or a lover or a friend. So this group also has more interactions with the law. Some end up in jail or in prison without receiving adequate treatment or support.
A third reason is our fragmented healthcare system. Sometimes health and wellness are lacking because the community lacks the kind of resources it needs to provide quality care. Primary care clinics that are the entry into the healthcare system may not be in the neighborhood. Specialty care clinics are often missing altogether. Often clinics that are available cannot be easily accessed. This can be due to a lack of transportation, especially affordable public transportation. Insurance coverage, especially public insurance, is often lacking for needed and desirable services, so patients cannot access or pay for care. Parity in insurance is equal pay for physical and mental health care. Parity is often lacking, so the quality of mental health care lags behind physical care. Recovery resources are often totally absent. There is also distrust of the system due to past negative experiences. Together, these problems describe the fragmented healthcare system.
Okay, so the fourth reason is lack of culturally relevant services. Many service centers and providers fail to address the needs of people in that community. Specifically, clinics are often not in ethnically diverse communities. They may lack service providers from ethnic groups or color that reflect that community. People want to receive care from someone that looks and talks like they do. This helps build the trust in the system. Oftentimes, healthcare services fail to reflect cultural priorities that reflect recovery and hope for this group.
And if we would be remiss if we didn't discuss medication, particularly with this group that may be on psychiatric medications. All medications have effects. There's a desired effect and there's other effects, which are often termed side effects.
Yes.
But they're all effects. Often psychiatric medication may unintentionally make physical health worse. For example, many psychiatric medications contribute to significant weight gain, which may lead to type 2 diabetes. This can also lead to high blood pressure and cardiovascular disease. Others can cause kidney problems. Patients and their provider team need to work closely to address these unwanted effects and balance these with symptom reduction with the person's informed choice.
So finally, some with serious mental health challenges have genetic predispositions or a tendency to develop serious physical illnesses, such as heart problems, diseases, and diabetes.
It is important that we realize that effective treatments exist for most of these physical illnesses we've talked about. There's evidence-based strategies, which means research evidence shows that specific interventions are effective for specific illnesses. We know there are effective medications for high blood pressure, effective treatments for many types of cancer, and even effective therapy if someone has a orthopedic injury like a broken ankle. We also know that we have top quality training programs for doctors and other healthcare providers to provide this treatment. Hence, there are healthcare teams that have mastered effective treatments that can help patients. The problem is that many people living with mental health challenges are not able to take advantage of these teams and treatments for a variety of reasons. One is because the perception that physical health teams are often unable to work well with people living with mental health conditions.
Okay, so we have just reviewed the sides of the concerns related to physical health and those living with serious mental health challenges. Let's now consider some solutions. Specifically, we'd like to talk with you about the benefits of peer support services. In the next several slides, we will summarize different versions of peer support providers. First, however, we summarize what is known about good treatment as the foundation on which peer support providers do their work.
We're also going to talk about integrated care. The problem is that mental health and physical health systems are often still separate. Integrated care is a possible solution, one place where the person can receive all health services, physical health and mental health care. This is one team that is able to address all concerns, one place for primary care, specialty care, and mental health care. Peer support should be a part of all of this. Integrated care is a good idea, but not yet fully a reality. One reason still exists that healthcare providers resist the call for integration. There still are many primary care providers who say, I was not trying to work with people with mental health challenges. The second reason is that insurance and government programs have not fully bought into the idea. They have not encouraged health providers to join together in an integrated approach. But now we're seeing some insurance companies have increasing interest in developing models that employ one single care manager to coordinate the care for a range of medical and mental health problems.
Okay, so what do we mean by peer support providers? Peer support workers are people who have been successful in the recovery process, who help others experiencing similar situations. Through shared understanding, respect, and mutual empowerment, they may provide practical assistance and support to individuals achieving their wellness goals. These are full and part-time employees who may or may not have a paraprofessional degree. They have lived experience with mental health challenges and often come from similar ethnic communities. They focus on hope, strength, and recovery.
The basic values of peer support that we're going to talk about today is that they are recovery focused. Namely, they are hopeful and supportive of personal aspirations and choice. The focus is on the relationship. There is no force or coercion involved in that relationship. Peer specialists promote empowerment in life in general and more specifically in regards to their healthcare decisions. They support people to identify ways to achieve their chosen health and wellness. Support is often provided in the community, but can occur in any setting.
Okay, so peer support specialists share selected aspects of their life with the patient. This sharing establishes credibility and support. It also provides an opportunity for the persons that is being served to learn possible ways that they might deal with health concerns. So this self-disclosure is often referred to as sharing one's story. The story includes some of the challenges faced and what they did about it, but it's not a life story, and the peer support always can choose what they want to share. So as far as me being a peer support specialist, as I said in the beginning, I meet the person that I'm supporting where they are. I share a little bit about how it was, what it took for me to get where I'm at, and things such as that manner. Second, our journey of recovery. I share about my journey of recovery and who and what has helped me along the way. Peer support specialists want to share their experiences with hope and aspirations and not talk about too much about or dwell too much on the bad times, but do identify that there were some challenges that we had to overcome. So sharing what worked for me or what's worked for others that I know can be very helpful when supporting another person.
So there are some limits to disclosure. Peer support specialists must attend to whether disclosed information is helpful to the people they're supporting or if it is not relevant in that particular situation. And again, it's always the peer support specialist's choice about what they disclose.
Yes, and we would never share what types of medications we take if we are taking any, because that may put thoughts into the person that we're supporting minds. Okay, so what else can peer support workers do? Programs have used peer support specialists to do three things in terms of a person's health and wellness goals. First is shared decision-making to support the person in considering treatment options and choosing those options that best meet their own personal goals. Second is to teach skills and provide concrete information and behaviors that help people self-manage their health and wellness goals. And third is navigation. Peer support specialists walk the person around a complex healthcare system. So we support them where they are and help them to get where they need to be.
I'm going to talk a little bit more about supporting shared decision-making. Good healthcare focuses on hope and possibilities, not poor prognosis and bad outcomes. Self-determination is key. Namely, the person decides for themselves what their healthcare goals are and how they might be achieved. Personal empowerment is necessary so that they can make informed decisions. And I always bring this up because as a peer specialist, I am not in a decision-making role. I don't consider it shared decision-making, but I'm supporting them to get all the information they have to make an informed choice. There is a stigmatizing belief that people with mental health challenges are unable to make decisions like these. That people with cognitive disabilities, for example, prevent them from being clear-headed and sorting out evidence for the best decision. I believe this belief is wrong, and peer support specialists are in the best place to challenge it. The peer supporter does not make decisions, but supports the person by helping them understand what the healthcare provider may have said by using non-clinical everyday language. Peer supporters help a person explore all options and use a person-centered approach so the person has all the information that is needed for them to make a decision about their own healthcare.
Okay, so we also teach skills for self-management. So people living with serious mental health challenges oftentimes need basic information about specifics regarding their illnesses and wellness goals and corresponding treatment options. Peer support can help people create questions to ask their providers and role play visits with providers to empower people to be more comfortable in these situations. Some examples include exactly what the illness is. For example, what does it mean if I have type 2 diabetes? And how will it impact me for the rest of my life? Another example is, what are all the treatment options, medications, surgery, hospital-based therapies, as well as lifestyle changes or complementary therapies that I may need to engage in. And so this discussion should be limited to evidence-based priorities. So peer support specialists, we support people in creating wellness goals as well as concrete ways that they might be achieved. I like the World Health Organization definition of wellness: state of complete physical, mental, and social well-being, and not merely the absence of a disease or infirmity.
So we can also help someone address behaviors that they may want to change. People with serious mental health challenges can benefit by learning about specific behaviors that may help them attain their health and wellness goals. This might include things like stress management, with strategies like meditation that may decrease anxiety in a situation. We may discuss healthy eating strategies and activities that help people reach their exercise goals, and making social connections in the community of their choosing.
Okay, so we also help the people we support navigate the system. So this is an opportunity for the peer support specialists to help people use skills in the world, such as finding services, going with them to appointments, going shopping together, participating in a wellness program in one's community. So when a peer support specialist works with a person along these lines, it's a great opportunity to continue to build that relationship, that work relationship with the person, and learn more about who they are and things that will help them or things that they desire to see change.
We often hear people refer to peer support as, they're just transportation for a person, but we like to take advantage of that time we have with someone. If we're on public transportation, we're having conversations. If we're shopping, we're discussing different things that we're seeing. And it's a way to build that connection and relationship. Some of the skills peer support specialists have that assist in supporting a person so they better understand their health and wellness goals are active listening skills, which are a set of principles and practices that allow peer support specialists to be present for the person and share with him or her or them the perspective of living with challenges. The goal here is to promote recovery, hope, and empowerment. Using active listening, peer support specialists may help people make a list of the goals they wish to pursue in terms of health and wellness. The peer support specialist assists people in analysis of the pros and cons of a specific goal so they can better understand what needs to be done to achieve it. The strengths model seeks to help people achieve their goals by focusing on strengths, not deficits. Focusing on what the person already can do or can learn to do will promote growth with the individual. As an advocate, a peer specialist works in favor of the person by providing support and promoting their interests. Ideally, we advocate with the person, not for them. Peer specialists only act as advocates at the request of the person we're supporting.
Okay, so what might peer service providers do for COVID-19 and other infectious disease? Peer service providers may have an important role during the COVID-19 pandemic. Matter of fact, we do. Most likely, our work would be done virtually. So there are a lot of telehealth going on. So peer support specialists will support and encourage people to shelter in places recommended by the local public health authority, especially if they have been exposed to someone that tested positive for COVID-19. On a day-to-day basis, I'm contacting people and letting them know that they have been exposed to someone that tested positive, and I'm recommending that they quarantine for 14 days. I find out if they are able to quarantine from other family members. But on a day-to-day basis, after that initial call, I continuously call and check on them to see if there's any changes in their health or in their symptoms. So people should regularly check for increased body temperatures. I ask them if they have a thermometer at home, if they have masks at home, if they have been tested, do they know the signs and the symptoms of having COVID, and they have any concerns. So I'm basically supporting them during this pandemic and helping them to overcome or address some of the uncomfortable feelings that they are experiencing due to the pandemic.
We also are in our unique position to support people through managing fear and uncertainty and the stress that comes from being isolated and not having, physical human contact.
Yeah.
Next, we're going to address the role of research in program development. And of special interest here is the role of what we call Community Based Participatory Research, or CBPR, relating to public health goals.
Okay, so community-based participatory research is more commonly known by its acronym CBPR. CBPR is based on the insight that programs that are developed for a specific community must include individual users of healthcare services from the underrepresented groups in that community. This is where community-based participatory research can be used. Collaborative, unique strengths, importance of community, improves communities, and eliminates disparities.
Inspiring Change is a project that was created to address the obstacles by involving African Americans with mental health challenges in all stages of the research process. The program was developed in 2015 through a grant sponsored by the Patient-Centered Outcomes Research Institute and the Chicago Health Disparities Center. Through this, they first developed a workbook and then a manual.
Okay, so Inspiring Changes identifies 3 groups of people to work with community stakeholders and design the program: people with lived experience, academic researcher, and community advocate. First among these experts are people with lived experience, people with the health conditions for which specific care programs are being developed. There are people in recovery. These people should reflect the ethnic, diversity of the community. Second are community advocates or perhaps service providers, the professionals and paraprofessionals who will be charged with carrying out the newly developed program. Third are the researchers, people who have a sense of existing research literature from which ideas may be drawn for program development. The researchers also know the kind of measurement and method issues that are important to competitive program evaluations. Next slide, please.
So the Inspiring Change program teaches teams about 3 types of CBPR. The goal here is to frame CBPR as a research enterprise that leads to answers that advance program development for that community. Hence, each type is defined by a specific research question with a corresponding set of methods to answer the question. First, there's understanding the problem. And we're gonna work through an example here that might be why emergency room use is so high in a community. One way to answer this question might be development of a survey that can be handed out at local emergency departments, asking users for their perceptions about the cause. Second is designing the solution. Based on findings from understanding the question, the team will work together to develop a way to handle a community health program. An example might be development of a nurse helpline to provide at-home advice that might detour an ED visit. The method here is a survey of ED service providers regarding needs to set up this kind of helpline. Finally, there's testing the solution. The CBPR team might develop a program evaluation project to test a newly developed program. In this case, they might want to know how effective this newly developed nurse helpline is in diminishing emergency department visits. This kind of evaluation might be done by counting changes in visits before and after starting the nurse helpline.
Okay, so with PCORI resources, Inspiring Change was used in 2 studies to develop a community-based healthcare program for people of color living with serious mental health challenges. Leadership qualities needed were outlined from the first project. Hence, we developed a second program called Leadership Training to prepare people with lived experience to be full partners of the CBPR teams. So some of the topics was introduction to research in CBR, leadership styles, communication skills, project management, leading a meeting, professionalism, self-care, mentorship, and solving problems and managing conflict.
So our next part, we're going to briefly discuss 3 PCORI funded research programs. And after that, we'll have time for discussion. These 5 PCORI funded studies are in fact specific to the health and wellness needs of people living with serious mental health challenges. I realize this might be hard to read right now. When you get the slides, each of these, you can click on a link and go right to that study. 3 of these studies have been completed and 2 others are still ongoing. And today we're going to summarize what was found in 3 of the completed studies.
Okay, so the Bridge program. This is the first PCORI funded study that we're going to review, conducted by John Brake from the University of Southern California, titled, Can People with Serious Mental Illness Help Peers Manage Their Health Care? The project tests the Bridge program compared to treatment as usual services. The Bridge program seeks to improve health care access, utilization, and its impact on self-confidence in managing one's health as well as overall health concerns. Bridge did this by helping peers who are people in recovery from mental illness, teach research participants health skills. The Bridge program manual that was used to implement the intervention. The intervention is augmented by motivational interviewing, education about illness, modeling skills, and practicing the new skills through the assistance of the paraprofessional. Bridge is a 6-month-long program.
In the research evaluation, 151 people with serious mental health challenges were randomized to mental health care as usual, or the control group, or Bridge plus mental health care as usual. Data were collected at baseline, 6 months, and 12 months. The measures included the number of routine visits and screening as an indication of engagement, and participants' perception of their relationship with their healthcare providers. Second, confidence in self-management was assessed by asking participants to report their sense of confidence in making decisions about their health. Third, 2 sets of health concerns were assessed. One is chronic disease, or the degree to which research participants were concerned about ongoing and persistent physical illness. And the second is their overall perception of bodily pain.
Okay, so this graph shows change in perceived confidence in managing one's health care. Note a significant improvement for people in the Bridge group, while the control group actually showed worse confidence.
So in these 2 graphs, the solid orange is the Bridge group, and the dotted is the control group.
Okay. All right, next.
The graph shows changes in concerns about chronic disease. You can see people in the Bridge group showed significant improvement in disease management concerns. And the last is body pain severity. This index is reverse scored, so that a negative change score means less perceived bodily pain. Once again, we can see significant improvement in perceived pain for the Bridge group compared to the control group.
Okay, so here we're going to talk about the second PCORI funded study, which was conducted by Dr. Patrick Corrigan from the Illinois Institute of Technology, titled Peer Navigator Support for Latinx Patients with Serious Mental Illness. In the effort to be fully transparent, Dr. Corrigan, PI of this award that we are highlighting, is also the PI of the overall dissemination grant supporting our presentation today. This study developed a peer navigated program called PNP using Community Participatory Research, again, CBPR. A manual was adapted to train Latinx with lived experience to become peer navigators. In this case, peer service providers were Latinos and Latinas in recovery and living with a serious mental health challenge. They helped research participants to better engage in health services. In the process, research participants were expected to better address their health goals. The key element of this peer navigator program was to literally walk the service recipients around the complex and fragmented healthcare system. The peer navigator program was a 12-month program that collected data at a baseline, 4 months, 8 months, and 12 months.
There were 110 Latinx enrolled in the program, all diagnosed with a serious mental health challenge and current physical health concerns. They were randomly assigned to the PNP or to the integrated care as usual group. 2 sets of measures were collected. First, service engagement was assessed by counting achieved appointments each month. Second, perceived effects on health were measured on self-reported recovery empowerment, and quality of life.
Okay, this last graph shows changes in quality of life from baseline to 12 months. Once again, steady and significant improvement is seen in the PNP group, while quality of life in the ICA control group did not really change.
In all three of these graphs, the dashed dark black line is the group that had peer support in addition to the treatment as usual. The first graph shows a clear interaction with steady improvements in self-reported recovery. The self-empowerment measure is reverse scored, so lower scores represent more empowerment. Once again, there was significant interaction that shows where PNP empowerment improved in the course of the study, and the control group was mostly steady.
Okay. So does the peer-led program with wellness coaching improve wellness among people with SMI? This last PCORI funded study was led by Sherelle Bellamy from Yale University. Using community-based participatory research, this group developed the peer-led wellness coaching program. The PWLC was a 6-month program, and it included 3 months of peer-led groups, educating participants on personal wellness, stigma, and self-management strategies. In addition, program participants received 6 months of individual wellness coaching offered by a peer provider.
There were 74 people enrolled in this program. They used quasi-randomization in the design, and participants were assigned to the wellness coaching, and 37 were assigned to treatment as usual. There were 5 sets of measures collected, including the number of emergency room visits, participant reported changes in alcohol use, general wellness, measured how participants perceive their overall wellness, and the last 2 are participant reported input into their treatment plan, and finally self-reported satisfaction with treatment.
Okay, so this graph here does not represent exact data, but demonstrates the general trends between 2 groups. Compared with participants who receive usual care, participants in the program show fewer psychiatric or substance use emergency department visits, greater decreases in alcohol use, greater improvements in general wellness, more treatment plan input, as well as greater treatment satisfaction.
All of these findings were statistically significant except the self-reported alcohol use, although there was a favorable change.
Okay.
So when you get these slides on these, if you click on either of these links, it will take you to the website where you can actually view and download the manuals that were used.
Okay, moving forward. So now we're at the final stage of our presentation. We hope to involve you in a discussion of how to move forward. We want to address dissemination, implementation, and sustainability issues reviewed earlier in this presentation.
Some of the barriers we've identified to implementation are: 1, there's a shift in practice culture. There might still be members of the existing provider team who believe paraprofessional or peer supporters cannot be effective employees. Some may not want to work with people with lived experience. There is also cultural changes for people receiving services. If someone has been in a system very long, they have not learned to be an active participant in their care. There is also identification and selection of the workforce, training and a discussion of certification. How will these folks be supervised? How are we going to evaluate the program? And lastly, how is it going to be paid for?
That's a big question.
Well, we're answering any questions. We'll leave this up. This is Patrick Corrigan is in charge of this overall program. That's how you can reach him, and that is my email as well. There's also, when you get the slides, there's a list at the end of references for the material that was presented here.
All right, great. Thank you so much, Pamela and Martha. We do have a few questions, and I know folks are actually still typing questions in. So feel free to do that. The slides will be uploaded on the NIAPRS website along with the presentation. So I know we had a lot of questions around that. And we also had questions around CEUs, so I just wanted to review that real quick before we get into the questions. CEUs will be available for LMHCs, LCSWs, MSWs, and CPRPs. We're working on getting the peer CEUs, so hopefully we'll be able to give you some of those sometime soon. And in order to get those CEUs, you'll receive an email after the webinar today at the email address that you used to register for today's event. Fill out that evaluation. It's an online form. Send that back, and you'll get your CEUs within about 45 days. And I will, yes, somebody just asked, can I put the website in the chat? And I am doing that right now. So that will be in there as well.
Okay, so I would like to answer a question or two. So I want to ask a question from Alicia Ward, and her question is it necessary for a person in need of peer support to have health insurance? And there are some places that do not bill Medicaid or in order for a person to receive services. Here in North Carolina, a lot of peer support services are billable services, and that's usually comes from a provider within our community just providing services. However, we do have some peer centers, such as Green Tree Peer Centers, in which a person can come there and they do not have to have any type of insurance. Martha, would you like to address that as well, if you know anything more?
I think you did a fine job.
Okay. And so
I haven't looked at the chat, so I haven't seen questions.
Okay, I have another question here from Teresa Ramirez, and her question is, what would be a reasonable caseload for a peer specialist to assist? And I'm just gonna say it depends on who you're working for and what you're doing. I have worked for an agency in which I was on the ACT team. I was not the only person working on that team, but we had at least 26 people, and I wouldn't see them every day, everybody every day, but we would divide it up, you know, break it up into increments as far as going out to see them. So I may see at least 4 people per day. I had worked with another provider in which was billing for services, and I had about 4 people, and each one of those persons, there was allotted so many hours, billable hours to work with that particular person. And so it just depends on who you're working for and what your purpose is.
And peer support occurs in all kinds of settings. So there are settings where you don't have a caseload. And one thing to keep in mind is one of the basic values of peer support is that it's voluntary, meaning the person that you're supporting chooses to be supported. So it's a problem if your supervisor or the organization you work for says you have to see this person, because if they don't want to see you, that's their choice, and we have to honor that.
Right. Yeah,
so Pam and Martha, we have a couple of questions that came in a little bit earlier, and I'm wondering if you'd like to address them. Can I read you a couple?
Sure.
So one question is directly related to the second research study. The question is, were the peer support specialists providing services to Latinx individuals, also Latinx? So are the peer specialists can they identify with the culture and racial ethnicities and backgrounds of the folks that they're providing services to?
Yes, in that study, so these weren't all necessarily people that were like certified peer specialists. They were people from the community that were doing well, you know, themselves. So they represented the ethnic diversity of the community, and they actually lived in the community. And that's one of the most valuable things, because they know that community. It's not someone coming in that lives across town.
That's helpful, thank you. What would you recommend to shift the practice culture to embrace peer support services? This is a big question.
I would say that's one thing that we're always working on, and there's examples of where it's just going splendidly, and there's other places where, you know, peer supporters don't feel valued and respected. And part of that is, you know, networking with each other and finding out, you know, where are those places that are doing well, and what does that look like? And if we collaborate with the other professionals we're working with, and can present information to an organization that might be struggling, where they're learning from all of us, they're learning from peer support, they're learning from the providers we work with about, you know, the benefits of this collaboration for all. And, you know, it's I must say, as I see people nationally, it's kind of hit or miss. Even I've seen it within an organization where one team just is working so well together and another team struggles. And I think the more we can share information and network, the better we'll be with this.
I agree with Martha. One of the things I do here in North Carolina for Forsyth County, a group of stakeholders got together and we looked at gaps in the system, basically a sequential intercepting mapping. We talked about people that had SMI that were incarcerated and the services that was available for them. And with each one of those intercepts that we went through, I was standing in the background, I was yelling, use a peer support specialist. A peer support specialist can do that. So in our state, in our community, we have a whole lot of great and wonderful services. And I believe it's a matter of just bringing them all together and implementing a peer support specialist within that team. So one of the things that I'm doing with this SIMS that we did in our community, I am doing presentations in as many places as I can, basically talking about the gaps in our systems and how we can implement, or they can implement, peer support specialists so that they can be part of the change, part of helping other people. And you know, that's what it's going to take. It's going to take us talking about it and then seeing the evidence that peer support specialists are a great asset with providing support to those that need it.
And I would say we're often asked, well, where's the evidence? So we presented 3 studies today that show evidence, and there's a lot of evidence out there now. And sometimes they need to see it, not just hear it from us. I like to say evidence.
Right.
All right, just a couple more questions for you. One is, can you talk about who supervised the peers in these studies?
So it was different in every one, and neither panel participated in these specific studies. But the one, there was actually 2 that were the Chicago Health Disparities Unit, and the Chicago Health Disparities Center is an organization that has integrated peer support throughout. So there were all kinds of people involved in that, but there were peer supporters involved in the supervision of that. They were involved throughout that study from its inception to the reporting.
That's helpful. Another question came in just now about engaging Latinx, young adult Latinx individuals. So maybe you could briefly just talk about, for these studies, the age range.
I actually have to say I don't know. I don't even know if, I think when you get the slides, you can go to that report. I'm not even sure if that was one of the comments that was reported out, but we are seeing so much more peer support now for youth and young adults. And just like we talk about, cultural diversity with regard to race or background, age comes in there too. I'm going to not do as good a job connecting to a 22-year-old as someone in their 20s. And that's where in peer support, we can still provide peer support, but in certain situations, we need to know when it's the time to say, I'm going to connect you with someone that I think will be able to better support you than I will. And it's nice if we have a network where we can do that.
Okay, another question here about recruiting peers. So this individual said that they come from a mid-sized city and systemic racism is keeping minorities from learning about peer services being available. They need to recruit and train more minorities for the behavioral health workforce. So how do we address this and recruit and train more individuals to become peers, more minority individuals to become peers? Any insight on that you'd like to share?
I would say it begins within the provider of the agency. For myself, when I got into the field of peer support, it was just wonderful doing what I did. And so I met the people that I supported where they were at. But at the same time, I'm giving them as much as they possibly could take. If they requested, I educated them on the benefits of, doing what they could to take care of themselves and becoming or doing peer support as well. So I like to give people information because they're curious when we first meet with them as a peer support specialist. I ask them for one thing: are you familiar with a peer support specialist, who we are and what we do? And that begins, a conversation, because we're able to say, I have life lived experiences. I may have went through some of the things that you are currently experiencing. Someone supported me, and now I'm here to support you if you allow me to. But it's about educating the people. Doing presentations in the community, having conversations about peer support specialists, and just spreading the knowledge everywhere that you possibly can. But I think it's also very important that, if a person goes to a provider to seek help or whatever, that someone on that team encourages them and empowers them, and let them know that they can become all that they were created to be.
And I would just add on to that. That was beautiful, Pamela.
Thank you.
Historically, even if we look at the demographics of peer support specialists, it's still largely white. And if we're providing a training that was designed totally by people that look like me, and I'm saying, okay, people from other cultures, come do this, I need to include people of those other cultures in the development of that training, because recovery doesn't even look the same in all cultures. So there's often a lot of, we talk about stigma or discrimination about having, mental health challenges, and it can be very intense in different cultures. So we need to include people in all stages, just like in this research. We need to include people in the development of what peer support training looks like and the implementation of it, because it might not be the same for all of us.
Exactly.
All right. Thank you so much. It's a little past past the hour, so I'm going to turn it over to Harvey to close us out and to thank everyone.
Absolutely. Folks did a wonderful job, and you can hear you see in the chat box how well received and popular your presentation was. We'll have to have you come back for part 2 in the future. Thank you so much. And
Thank you.
we put in the chat box that there are other, on the website, a number of other webinars in this series, and we had a virtual seminar earlier this year. So most of them are recorded. You have slides there. Please take a look. But really, on this particular presentation, please go to the slide where they have the studies, because they're so rich. You're looking for data, well presented in a very attractive manner. That's the place to go. So thank you, Pam and Martha. Thank you so much for joining us. And we will be back next week. I think, Daniela, with what? Who's next on the docket? Is it Patrick?
Patrick Henry is next week, up next week.
Loneliness. Okay, so come back for that. And then at the end of the month, we have a history of the movement with some real pioneers, Sally Zinman, Joseph Rogers, and Celia Brown. So we'll see you then as well. So thank you again, Martha and Pam.
Thank you.
And we'll see you soon.
All right.
Take care, everyone. Thank you.
Take care, everyone. Bye.
Bye.